Without further ado, I'll introduce our first speaker, Dr. Radhe Mohan. Dr. Radhe Mohan is a world-renowned medical physicist. He has extensive experience in the field of radiation oncology physics, including numerous pioneering contributions. Recently, his activities have been concentrated on various physical, clinical, and biological aspects of proton and light ion therapy. Dr. Mohan is also a principal investigator, along with a colleague at MGH of the US, of a program project granted entitled Improving the Clinical Effectiveness and Understanding of the Biophysical Basis of Proton Therapy from the National Cancer Institute of the US. Dr. Mohan, the floor is yours. Let's listen to your wonderful talk of overview of proton therapy.
Thank you, Wenhua, and thanks also to Joanna Diaz for the opportunity to give this lecture here. And I'll share my screen. And let's see, here we go. Share. I assume you can see it.
Yeah.
Okay. So I will introduce some relatively simple concepts of proton therapy, and then describe the current state of proton therapy and where we're going in terms of ongoing research and future research that I think should happen. So just nothing to declare. I don't know where these lines came from. Whoa, how do I get rid of this? Hang on a second.
You mean the red lines, right?
Red line. How do I get rid of these things? Let's see. Eraser. How do I get rid of these lines? I don't know.
I don't know what they could be, but if you want to share it via PowerPoint, perhaps they don't have any lines. Or are you sharing? Oh, you're on PowerPoint already.
No, this is just this morning. I was looking at this morning, but I don't know how these came about. Wow. How did this happen?
Maybe just you could share it that way if you want to. It's not that disruptive, I believe. Or you can send me the slides and I'll share them as you wish.
Well, what you get, hang on one second. Just
Sure.
about.
No worries.
Oh, it's on the screen itself. It's not
exactly. It's not the
so,
PowerPoint.
Not the PowerPoint. Okay. Let me
Dr.
just
Mohan,
share them. Yeah, I'll switch to.
Yeah. Can I suggest how to fix it?
Yes.
Please go to View Options and look at Annotations, Clear Annotations.
View options of what? The PowerPoint?
So in the Zoom screen, you have something at the top labeled View Options, a tab.
Okay, hang on a second.
Click on that.
Okay.
And at the bottom tab, there is Annotate.
I'm looking at.
It's on the top, in the top, center top, Professor Mohan.
Okay, annotate, yes.
And there should be, you should have an option of clear the annotations. Clear.
Annotation.
I don't have that, but I'm not the speaker.
Okay, eraser. I see. Select, text, draw, stamp, spotlight.
Is there an option to erase?
There is an option to clear.
Okay, there's an eraser. Okay, yeah, there you go. Good erase. Sorry about that. Okay.
No worries. Thank you so much for your help, Professor Carroll.
Okay, so I have no idea how that happened, but it was not on my on my, now you can see my screen, correct?
Yes, we're still seeing your screen.
Okay, all right. So now I'm going to go back to my regular
Mhm.
and sorry for the,
No worries,
okay, so no conflict of interest.
for sure.
Okay. And so brief history. And now how do I get rid of this one here? Here we go. Okay, brief history of proton. So it started with Robert Wilson in 1946. He proposed that protons can be used for treating cancer patients. And then first patient was actually treated in 1954 at Berkeley. And after that, many particle accelerator physics labs started treating patients with protons. And the best known example of that is Harvard Cyclotron Lab and MGH, where I think most of the work in the between 1970 and then 2000 was done by Michael Goitein and Herman Soot. And then Loma Linda was the first hospital-based clinical facility. And the first use of scanning beam protons, that was a two-dimensional IM, intensity-modulated proton therapy, was at Paul Scherrer Institute in 1996. And then MGH built their clinical facility in 2000. They started treating patients in 2001. And then MD Anderson in Florida started treating patients with protons in 2006 in the hospital-based clinical facilities. Three-dimensional intensity-modulated proton therapy was introduced at MD Anderson. I think it was about 2010, but Dr. Gunn can probably put a more precise date on that. And since the early 2000s, there has been an explosion in particle therapy centers. More than 100 centers are at the end of 2020. There were more than about 100 centers around the world, and 60 more were under construction or were planned. So obviously, people think that protons are important, so they're building more and more, even though the cost is very high. Let me get rid of this screen on this. How do I do this? More. Hide video panel. Okay. So up until the end of 2020, about 250,000 proton patients have been treated. However, this number is relatively small, perhaps 1% or less, compared to all the radiotherapy patients treated around the world. But the question is, why proton radiotherapy? And the answer is basically the physics. Underlying reason for using this is the physics of protons, and that's they can produce dose distributions such as the one shown here in the red Bragg curve. And there's they can produce those characteristics that could have considerable therapeutic potential. At the same time, we have to realize that protons are very different from photons, not just in terms of the physical properties, but also in their biological and immunological properties. And that it's really important for us to understand these differences in order to maximize their potential. So as I'm implied that the protons derive their potential, clinical potential, from the physical properties. So protons, as they penetrate the tissue or the medium, they lose their energy continuously, and the rate at which they lose their energy continues to increase as they penetrate deeper and deeper. And the rate of energy transfer, linear energy transfer, or LET, and the dose deposit increases continuously with depth, forming the characteristic Bragg curve, such as this line here. This is the Bragg curve, and this is the linear energy transfer curve here, the dashed line here. And as they slow down as a function of depth, protons ionize more and more densely. And more densely ionizing protons lead to increase in magnitude and complexity of biological damage, and therefore the relative biological effectiveness. In other words, the RBE, relative biological effectiveness, increases first slowly and then rapidly, and as does the LET as a function of depth. So protons deposit less dose before the target, and then they stop abruptly, forming after they have lost all their energy, forming the Bragg curve. And what that also means is that they have a finite range, and that leads to very compact dose distributions, which allow us to spare normal tissues as well as the immune system. But at the same time, the sharp drop-off of protons at the distal edge makes them more vulnerable to anatomy changes in the path of the beam. Now, there are different ways of delivering proton therapy. One of them I call it the old-fashioned way, and that's how we started, and that's how most of the treatments have been delivered to date. But I think very rapidly it's changing into scanning beam technologies. So the old-fashioned way is the passively scattered proton therapy, PSPT. And in both cases, though, there are multiple beams that are incident on the target from different directions. And for each beam for PSPT, a narrow beam enters the nozzle or the treatment head, and it is scattered and then modulated electromechanically and shaped by beam shaping devices, the collimator, the compensator, et cetera, to produce a dose distribution pattern that fits the distal edge of the target. And each beam is designed to irradiate the target volume as a whole. And the intensity modulated proton therapy delivered with scanning beams, there are also multiple beams. And that uses magnetically scanned pencil beams or beamlets of a sequence of energy. So for each energy, a layer is scanned and then the energy is changed. So that way you can produce a three-dimensional pattern of dose distribution that may partially or wholly cover the target volume. And in a three-dimensional treatment plan, IMPT, the beamlet intensities of all beams are optimized simultaneously to achieve the best possible results for the target and sparing of normal tissues. So what happens with this three-dimensional IMPT that I just mentioned is that each beam may only partially or inhomogeneously irradiate the target volume. But the sum of all these adds up to very homogeneous dose distribution in the target, and at the same time optimally sparing normal tissues around it. This is a beautiful picture from Tony Lomax, a rather old picture, just to illustrates the point that how 3D IMPT works. IMPT is much more powerful, as you can imagine, than passively scattered proton therapy as well as IMRT. And this is another example from Tony Lomax. This is for nasopharynx. And you can see that compared to IMRT, where the dose is spilled to regions outside the target, the IMPT dose distribution much more compact, much more sparing of normal tissues around the target. And this is another example from my colleague, Joe Chang, which is showing a three-dimensional X-ray radiotherapy versus IMRT. IMRT is better than 3D CRT. Passively scattered radiotherapy is superior compared to IMRT. And as you can see, the IMRT is much more conformal and has much smaller dose bath than any of these. So while in principle, proton therapy has greater potential, there are numerous challenges, there are numerous limitations it has. And what I'm trying to say is that although we are beginning to see better and better results as we are learning more about proton therapy, there are still a lot more work to be done. I think proton therapy has a lot more potential than has been realized to date. That's the point that I would like to emphasize. Many of the examples I may show, many of the examples that I'll show may cast protons into a negative light. But the point is, I'm trying to say is that so far the results have been kind of mixed, but proton therapy has a lot more potential, and a lot more work needs to be done to maximize that potential. So the kind of impediments that may limit the effectiveness of proton therapy, I have a list here. The anatomy changes, as I mentioned, may perturb the dose distributions to a significantly greater degree than for photons. High gradients in proton dose distribution, mainly at the distal edges, make it very sensitive to anatomy motion and changes and to setup variations. We have big gaps in our knowledge of relative biological effectiveness. Currently, we assume it to be just a constant of 1.1. Then the other point is that there is heterogeneity in patient population, tumor characteristics, and treatment techniques and other factors. Even though there may be a difference between proton and photon, but because of these heterogeneities, the error bars in response are so large that we cannot see the advantage of protons over photons. Another factor is the evolving treatment delivery and planning systems. We still, it's still an immature technology. I think IMRT and photons have been around for much longer, and they are much more mature than the proton therapy technologies. And then I think we have a tendency to apply the same knowledge, what we learned based from photons to protons. And that may not be appropriate. And I'll give you at least one example of that. And the high cost of proton therapy. So while the original expectations were very high when we started proton, clinical results so far have been mixed, some good, some not so good, but there are continuing to be gradual improvements. So here's an example, an old example, where what you see on the left-hand side is the treatment plan done for using a fixed CT, standard CT. And what you see is the yellow prescription isodose line, and that seems to cover the target very well. But if you look at all 10 phases of the 4D CT image, in other words, simulating the tumor motion, you can see that the prescription isodose line is perturbed quite a lot. And so the dose actually delivered may not be the same as what we see on a fixed treatment plan. Here is another example. This is not showing any isodose distributions. However, what it is showing is how the anatomy may change interfractionally. The other one was for intrafraction motion. This is for interfractional changes in anatomy. And you can see this is clearly going to perturb dose distribution from day to day. So although IMPT is much more powerful than passive scattering proton therapy, it is also more sensitive to inter-intrafractional motion and other forms of uncertainties. And this is explained in this slide here. This is the same slide that I just showed you. Now, all these dose distributions individually are very heterogeneous in the target and around in the normal anatomy. And they all combine sort of like fit like a jigsaw puzzle to form this exquisite dose distribution. But in the presence of in uncertainties, that fit is lost. And that means the dose distribution that is delivered here will no longer be as beautiful as it seems. In fact, and both not just in the target, but also in the surrounding normal tissues. So in other words, because of the way it fits, the dose distribution from inhomogeneous dose distribution by individual beings fit to produce this dose distribution, that fit is lost, and the dose distribution could be much different than what you see on the treatment plan. And another challenge or another limitation is, as I mentioned, the gaps in our knowledge of biological effectiveness of proton therapy. The RBE has been and continues to be assumed to be 1.1, even though I think we began to realize maybe at least a decade ago that RBE should be something different. It is still mostly used, assumed to be a constant 1.1. In reality, it is a complex function of linear energy transfer, energy spectra, dose per fraction, tissue and cell type, endpoint. And as I mentioned to you, although there has been gradual acceptance, by and large, we continue to use 1.1. There are a few instances where people are beginning to use variable RBE models, but even those models are relatively limited in their ability, but still it's better. They're better than assuming the RBE to be 1.1. And here's some data showing the variability of RBE. This is the panel that I showed earlier. So as you can see, this is from my colleague Farah Guan. And what it is showing is that the RBE can be lower than 1 or close to 1 when at the entrance point, and at the Bragg peak, up to the Bragg peak, it is continuously increasing at a relatively slow pace. And then after the Bragg peak, it begins to rise very rapidly to as high values as more than 3. And this panel here shows the RBE as a function of dose. As the dose decreases, 2 gray per fraction, as the point of measurement moves along with the position on the spread out Bragg peak, the RBE increases, and then when the dose is very high, the RBE is close to becomes a constant. This is a very interesting panel here. What it shows is that for different lung cancer cell lines, the RBE is different depending upon the genetic factors, the DNA repair defects, DNA damage repair defects. And what you see here is that for some cell lines, the RBE could be as low as 0.9, and for some other cell lines, it could be as high as 1.6. And by the way, these measurements in this panel were made in the middle of the SOBP. So LET and dose were the same for all of these cases, but they're just the biological factors that determine the relative biological effectiveness. So we know that there are limitations. What are the clinical consequences and of the gaps, the uncertainties and gaps in our knowledge? Well, one is that biologically effective dose distributions that are actually delivered may be different from what we really intended. And then that may affect outcomes compared to what we expect. So here's an example, and I have this sad face here indicating that the original expectation was very high. This was a randomized trial. We started in 2009 and ended in 2014. And the original expectations were very high. In fact, there were people who were telling us that we already know protons are better. We should not be doing this trial. It will be unethical, or that the patients will not accept to be randomized and so on. However, we were able to start and complete this trial successfully. And by the way, Dr. Liao was the principal investigator on this trial. This is a part of our NCI-funded grant. And what we found was that there was no statistically significant difference between the endpoints, which are primary endpoints. One of them was the grade 3 or higher pneumonitis and local failure. Both were the same in both photon arm, IMRT arm, and passive scattering arm. By the way, here we did not have IMPT at the time of this trial. We were comparing IMRT with passively scattered proton therapy. So then, although the trial results were negative, we wanted to know what happened and what can we learn from what happened. And obviously, first thoughts were it could be the sensitivity of protons to interinterfractional anatomy changes, and simplistic assumption about RBE. Or, while we were applying proton therapy, we still continue to assume that we can extend our photon therapy experience to protons. In other words, we can apply the same dose and dose volume constraints when we're planning to do that. That may or may not be correct. And so it could be the inappropriateness of extension of photon experience to protons. Immature technology, evolving and techniques and learning curve, and so on. So there were many factors that we wanted to consider and also see if we can investigate from the data what might have happened. Here is one example, which was to see if photon experience could be extended to protons. So in lung treatments, we use mean lung dose as one of the constraints. What we found was if we were to plot mean lung dose on the x-axis and incidence of grade 2 pneumonitis on the y-axis, these are the results. So you can see that although groups of photon patients are closer to this line, the fit line, the fit with the proton data is very poor. And then we allowed the constraint, we reanalyzed the data using the effective dose, where we allowed this n parameter to vary, and we found that the best fit was obtained with a value of n close to 0.5, which meant that the incidence of grade 2 pneumonitis is more closely related to root mean square dose, which means that in fact it's not the mean dose necessarily, but that the higher doses received by some of the volumes of lung do matter. So in other words, we cannot ignore high doses given. We should not just, it's not just the mean lung dose. So here's some lung data, as you see here, that the mean lung dose and V20 was the constraint in both, and mean lung dose was the constraint, and they turned out to be about the same in both arms. But as you can see, that at lower doses, IMRT volumes are higher, okay? But as you go to higher and higher doses, the proton volumes are higher. Although the mean lung dose and V20 are about the same, there are differences in low dose volumes and high dose volumes. Another thing that we looked at was the heart doses. And you can see that heart also we try to limit the dose to mean heart dose to lower values. Although the mean heart dose is about the same, what you see is that the volumes mean heart dose was much superior compared to in protons compared to photons, but it was not associated with cardiac toxicity. Let me repeat that. Mean heart dose was lower for protons significantly, but we did not find it being associated with cardiac toxicities. Although mean heart dose we try to keep low to minimize toxicities, and we wanted to understand that. It turns out that Atkins et al. Presented a talk at Astro, and they also published a paper later on. It is not the mean heart dose, but perhaps high doses to heart substructures, for example, the left anterior descending coronary artery, that may be responsible for major cardiac adverse events. For protons, mean heart dose is significantly lower, as you saw, but individual substructures in which one or more of the beams may have distal edges, or they may stop where the LET is high, or RBE dose is high, may lead to adverse outcomes. So this needs to be investigated, and that's what we're doing in some studies we are doing, analyzing the data we already have. And there is also an ongoing clinical trial that is looking at that. Another study that I want to talk about is the retrospective analysis of pediatric ependymoma patients, so pediatric brain imaging changes with proton versus photon. This was led by another one of our colleagues, Jillian Gunther. And she looked at 72 patients, intracranial ependymoma. Proton therapy was given to 36 of these. And then there was a matched cohort of 36 patients, IMRT patients. What was interesting was that for IMRT patients, 17% had these imaging changes, whereas for proton, 43% had imaging changes. And even more critical was the fact that the high-grade imaging changes, which corresponded to hemorrhage and focal necrosis, there were 7 such cases for protons, but none in IMRT. And that kind of raised some alarm bells. And a colleague of mine, who was a co-author on this paper, David Grosshans, he approached me, to discuss what might be going on. And we thought that it may be the high LET at the distal edges and high RBE that may be the factor. So question was, are the image change differences between protons and photons due to high RBE, high LET at the distal edges? And a student of mine, Chris Peeler, did the analysis of data. He did voxel-based analysis. And what he showed was that indeed, the probability of changes in imaging of these voxels collectively are a function of not just dose, but also a function of LET. And as you can see here, that for different LETs, the response is different. And this is as a function of LET. These are the same data, but plotted as a function of dose here and as a function of LET here. There have been many other reports on brain image MR changes in process, and the 2 that I want to highlight are, one was an NCI report by Hans Kogan. There was an NCI workshop because of the concern that many people had reported the brainstem image, in children, brainstem injury reported by many investigators. And so out of concern for that, NCI held a workshop, and this is the report that I think is worth looking at. But the ultimate conclusion of this report was that we need to lower the prescription dose. I wish they had said that we need to find ways to reduce the LET in regions of the brain. In any case, that's what the conclusion of this report was. Another report that is very interesting, I thought, was a report by Bonn, I think it's from Germany, DKFZ perhaps, that there's clinical evidence of increased periventricular sensitivity and variable RBE. The regions around the ventricles are more sensitive than other regions. So that could be right. So in other words, we want to make sure to reduce LET or RBE weighted dose in regions near the ventricles. Another study that I would like to present is, I think, a positive one. This is from Mayo Clinic of oropharyngeal cancer, IMPT. Now they use IMPT versus VMAT. And this was also a retrospective study. And what they showed was that, well, they looked at 305 patients, 46 IMPT and 259 VMAT. And what they found was that the incidence of feeding tube was much lower for IMPT compared to IMRT. And you can see from this graph here, bar chart, that less than, so this is during, this is before radiotherapy. This is during radiotherapy. And you can see the incidence is much lower for proton therapy. This gray part is much lower proton therapy than for IMRT. And then hospitalization, as you can see, that no hospitalization for proton therapy, and about less than 10%, 8% is for protons, and about 30%, and some of them have to go to the hospital twice for IMRT, VMAT. In addition, 22% reduction for endotreatment narcotic use, reduced cough and dysphagia, and patients felt less ill and had better swelling. Another study of interest is the randomized phase 2b trial of proton therapy versus IMRT. This is also Fessus Gering. This is Adam D. Anderson by Stephen Lin. And the purpose was to look at total toxicity burden and progression-free survival of proton therapy versus IMRT. Excuse me. The total toxicity burden is the composite score of 11 different adverse events. There were 145 patients, prescribed dose was 50 gray, and there was no difference in survival though. However, the total toxicity burden was 2.3 times higher for IMRT than for proton therapy. And post-operatively, for those patients who went to surgery after radiotherapy, the difference was even much greater, 7.6 times higher for IMRT than proton therapy. And there have been many other reports in the literature, some negative, some positive. This from Kralik et al. But pediatric patients was negative, very high incidence of radiation necrosis. And then another one, positive one, was from MD Anderson about superior intellectual outcomes after proton therapy compared to photon therapy for medulloblastoma. And then, but most of the reports are like this, sort of feeble recommendations of at best modest improvements in proton therapy. Like many of them have this radiotherapy associated cognitive effect appear to be more attenuated and after proton therapy, and that the comprehensive prospective studies are needed. In other words, it's not a very strong endorsement of proton therapy, and most of the reports that I've seen tend to be that way. I also like to suggest that people who are interested look at the paper by Prasenna et al. In Red Journal of 2021. They have reviewed many clinical studies and reported on them. We find very useful. So the clinical outcomes are somewhat of a mixed bag, although I think the theoretical potential is high, but the limitations of the state of the art, and these imply that there are ample opportunities for further research and technology development and improving our understanding and how proton therapy works. And then obviously to achieve better outcomes. And a lot of that research is already going on. Some of them is MD Anderson and NGH, but I'm sure all over the world. And results are gradually getting better. So although some of the things that I've mentioned may sound negative, but I think there is potential, a lot more potential than has been realized today. And outcomes are improving slowly. So I'll give a couple of examples. I don't have much time to go into much more. I'll give a couple of examples of some ongoing research and opportunities for the future. One of them, well, actually both examples relate to immune suppression with conventional radiotherapy and how proton therapy can be used to, how proton therapy may mitigate immune suppression. So I think many of you may know that radiation-induced lymphopenia or immune suppression is common across all tumor types that are treated with photons, but is often ignored because there's not much we can do about it. Our goal is to control the tumor, but if the side effect, just a side effect. High-grade lymphopenia is also known to be associated with poor disease outcomes, poor survival, and other side effects, other consequences. Oops. So we recently observed, in fact, Stephen Lin mentioned to me 3-4 years ago that proton therapy is less immunosuppressive than conventional photon therapy, and that could possibly be due to smaller dose paths. The lymphocytes are very radiosensitive, and so even low doses outside the target can kill lymphocytes, and that may be the reason for immunosuppression by conventional radiotherapy, but protons protect them to some extent. And so this was the paper published in 2017 by Stephen Lin's team. And they analyzed 504 esophagus patients, 187 passive scattering proton therapy, and 317 IMRT. What they found was that proton versus photon strongly influence the mean body dose or the dose bath. And that mean body dose was a strong predictor of grade 4 lymphopenia, which was in turn a predictor of survival. So here is the data that shows that grade 4 patients who had developed grade 4 lymphopenia after radiotherapy or at the end of radiotherapy did very poorly. By the way, this is from combined proton and photon cohort. So those who had grade 0 to 3 had a better survival compared to grade 4 lymphopenia patients. But then if you separate proton and photon, you also see there is a significant advantage for protons compared to IMRT. So this suggests that it's the lymphopenia is affecting, and there is an advantage of proton, at least for this cohort. So another example
Sorry,
is
Professor Mohan, please mute yourselves. If you don't mute yourself, I will have to kick you out of the meeting. Thanks.
Mute myself?
Sorry. No. The participants, there was some background sound. You can proceed, sorry.
Okay, sorry. Proton therapy, we also looked at glioblastoma patients who were also on who were on a randomized trial, by the way. And this is a small study, and we wanted to look at how there was a difference between protons and photons in terms of lymphopenia among these patients. We looked at grade 3 lymphopenia, which is considered to be high-grade lymphopenia for these patients, 84 patients. And what we found was that although in the beginning, the lymphocyte count was about the same for proton and photon patients, at the end of treatment, or the nadir value of ALC, the minimum value over the course of radiotherapy and afterwards, was lower for photon than for protons. And grade 3 was significantly associated with baseline lymphocyte count, whole brain mean dose, and brain volumes that received between 5 and 40 gray. And very interestingly, we found that grade 3 lymphopenia, grade 3 or higher lymphopenia, was lower, incidence was lower in men versus women. We don't quite understand why women are more vulnerable. However, if this is true, then what that means is that women can benefit from proton therapy more than men can, at least for the GBM patients. We did not find any difference in survival here, partly because the population is smaller, n equal 84, but it could also be that the GBM patient survival is very short anyhow, and we were not able to detect the difference. So the message for these two examples is that immune suppression by protons is less than by photons, possibly because of difference in dose bath. And the difference can be maximized further, and this is something research we're doing now, using IMPT optimization that uses the criteria that can reduce the dose bath and limits the exposure of specific immune organs at risk, such as spleen. And reduction in immune suppression may not only improve radiotherapy outcomes, but also enhance the effectiveness of immunotherapy after radiotherapy. And here is one example from Johns Hopkins, where there are 78 non-small cell lung cancer patients. They were treated with chemoradiotherapy followed by immunotherapy drug durvalumab. And what you see here is that 23% had severe radiation-induced lymphopenia. That's this graph here. And their survival was much poorer than those who did not as a result of. So the success of immunotherapy may depend upon the immune system's health. And if we can preserve that health with protons, that would improve the effectiveness of immunotherapy after radiotherapy. And just this morning, 2 hours ago, hot off the press, Stephen Lynn shared with me this manuscript that the impact of severe radiation-induced lymphopenia on the benefit of this durvalumab after concurrent chemoradiotherapy lung cancer. It's the same disease site, but it's a much larger study, and the severe lymphopenia significantly impacts progression-free survival and over overall survival benefit of durvalumab. So, so that's not the only research, but I think this is one of the more important areas of research that we need to take advantage of. There are many other examples of ongoing research, and I don't have the time to go into that. I'll just make a list here that my favorite list, and the opportunities for future. Of course, addressing uncertainties related to anatomy changes, things like advanced in-room imaging, adaptive replanning, respiratory motion management, etc. Filling gaps in our understanding of biological effects of proton therapy, modeling RBE based on preclinical data and clinical outcomes, and personalized modeling as opposed to population-based modeling, population-based averages. And that is really important because that will allow us to take into account the heterogeneity in patient populations. And these are the models that will take into account patient-specific characteristics such as age, gender, performance status, body size, etc. The point is that they will allow us to predict the risk of an individual patient as opposed to using a population-based averages. And our hope is that that'll be a much more accurate way of identifying what we should do for that patient. In other words, the dose volume constraints, for example, would be individualized to that patient. We will not use the same V20 and mean lung dose for every patient, but the constraints will be for that specific patient's characteristics. And then the voxel-based analysis, I think more and more institutions are doing it. Some of that work is going on at our place, but that will allow us to identify which subregions of the organ are more sensitive than other regions. Another area is the model-based selection of optimum treatment modality, and this was something that was introduced by Hans Langendijk of Netherlands. But in order to identify which modality should be used, I think we need high reliability, highly accurate predictive models. That's really important. So modeling is basically developing accurate models is one of the most important areas in this field. Technology development, I think we need to produce more cost-effective, efficient proton therapy systems that are also more clinically effective. There's a lot of work going on in the industry and in some institutions.
Já limpei tudo cá dentro.
Compact superconducting accelerators and gantries, upright treatment and imaging systems, and much more. Treatment planning systems are being advanced, and I think biological dose optimization, and we are working with Coimbra, Dr. Joanna Diaz, and others on beam configuration optimization and other areas. So to close, I just want to reiterate what I just said in the beginning, that proton therapy has considerable potential, much more than has been realized. Protons and photons are very different from each other, biologically, physically, immunologically, and understanding these differences is important. Anatomy changes that perturb proton dose distributions and the gaps in our knowledge about the biological effectiveness. They may have been limiting the realizing full potential of protons, and the immunomodulatory effects of proton need to be better understood and exploited. Clinical results so far have been mixed, but improving. There are great opportunities to enhance proton therapeutic ratio through further research. And with that, I thank you all for your attention. I'll be happy to take any questions, try to answer them.
Thank you so much. Everyone is welcome to send some applause or any reactions. And now it's time for some Q&A. Does anyone have any questions to ask? Okay, Carol Lang, you can mute yourself. Go for it.
I was wondering if you could comment on the importance of feedback imaging through either SPECT or PET on the efficacy of the treatment?
You mean specifically for protons, or?
Yes, yes, for proton therapy.
I'm not sure if I can. I'm not qualified to do that. But obviously, any kind of imaging in general, if you can use imaging to study response, which many people are, as we are, for example, that I mentioned about brain MR imaging, will definitely be of great help in understanding the effects of any kind of radiation, proton versus photons. I'm not sure that was the gist of your question. Certainly, I think any kind of imaging that can identify differences, that can.
Yeah, I was wondering whether that's being applied, done, and used in developing treatment plans, for example.
I think maybe Dr. Gunn, who is on the line, may have a better idea. He may be able to better respond to that. But certainly many kinds of imaging is used, CT, PET, MR. I think SPECT is also used, but I have not. I'm not sure if I'm the best person to answer that. Brandon, are you there?
Yes, Dr. Mohan, thank you. Yeah, so I will touch on some MR-guided adaptive proton therapy clinical trials that we have ongoing at MD Anderson. So maybe we can present it there and see if that helps to address it.
Sure, thanks.
Any further questions? Okay, José Miguel Silva, you can unmute yourself. Go for it.
Good afternoon. Can you hear me?
Mm-hmm.
So I have a question. From what I realized, from what I've read, it looks like that protons on the brain cause necrosis. Is there any study ongoing on how the protons affect specifically the brain on necrosis?
There is a study actually we are doing as a part of the program project, where we are going to try to understand. You see, the studies, the analysis that have been done so far indicate that there could be some high RBE type effect. But what happens is, as I understand it, is that necrosis may begin at one point, but then it spreads to perhaps even to regions where there may be the dose and LET may be rather low, and so makes the analysis difficult in terms of, because the dose and high dose or high LET may not correlate with changes in imaging, and so one of our goals is to try to pinpoint the region where the necrosis began. So that's one study that is going on. This is in collaboration with MGH. We have a fair amount of data that we can use to understand the connection between high LET and brain necrosis. Is that the kind of study you have in mind?
Yes, thank you.
Wonderful. Any other questions? Okay. Oh, okay. Joanna, go for it.
Thank you so much for this wonderful presentation. We have seen that there are benefits and also some potential disadvantages of using IMPT. These disadvantages can have somehow to do with the things that we don't know yet. But do you think that in the future, we can look at proton therapy as the standard treatment? So it will be what we will look for, whatever the pathology, or we will still have to make a choice regarding the best modality for each patient?
Right. I think once the models improve, and we can more accurately identify more accurately plan treatments, I think more and more patients will become clearly become suitable for proton therapy. However, I don't think it'll ever be a time when we can say that every patient should be treated with proton. There could be some situations where protons are equally effective, or there is no need for protons. So I think that's probably what will happen. Also, I think protons, the higher cost, even though the cost may come down, proton therapy facilities will be more expensive, more costly than protons. So I don't think it'll ever be a situation where protons will become a universal as compared to say photons. But the fraction of protons fraction of patients who can benefit from protons will increase over time as the models get better.
Thank you so much.